is that angulation. Now, I want y'all to be careful here because this angulation is different than the other ones we've utilized. Not only is it a different number, but it's a different direction in that we are doing 20 degrees cephalic, not caudad. Probably the biggest mistake people make on these mandible angulation x-rays is that they forget that that is a cephalic angle compared to the caudad. Because if you were to angle caudad, it would actually foreshorten the mandible because of the way it lays in the face. So you elongate the mandible, you got to utilize a cephalic angle in that PA position. Yes?
So is it imperative that we do upright, or do they have to be seated specifically?
Either way, I just prefer to stand my patients up. That's just me. As long as they're upright, that's the ideal way. And that's seated or standing. Smells like eggs in here. Smells like eggs. Charo, you look very guilty over there. Don't ever play poker. That poker face is just not working.
You want her to play poker.
All right, so there it is, guys. Now make note there is a range on this one. We're going to use a 20 to 25 degree cephalic angle. You can choose either one. And that is exiting at the acanthion. Exiting at the acanthion. And once again, the reason we're doing this is to elongate the rami of the mandible. And one thing to make note of, you probably noticed in lab, guys, when you do this x-ray, it looks like you have a ton of light on the back. Y'all remember that? But that's normal. It's supposed to look that way because the angulation, even though it looks like there's a lot of the back, you're not getting a lot of the back. You're still just getting mostly mandible. It just has to go through the shoulders and the back to get to it, to the position you're in. So don't let that throw you off. You're like, oh my God, I got all the person's back. You don't really. Not in retrospect. It's mostly going to be mandible. Just the way it's laying and traveling through the body. Angles distort things, so let that fool you.
SID is 40, right?
That's like, yeah, everything we're doing is 40, this chapter. Nothing is 72. Yes. Everything suspend respiration. Stop breathing. We're not holding, we're not blowing out, we're just suspending. Stopping. You know what's going to throw me off most about doing that speech this week is the fact that I have to have a clicker and a microphone. And I like to talk with my hands. If y'all haven't noticed already, I like to use my hands. It helps.
Why don't they give y'all lapels?
Yeah.
That's a good question. I would love to know that answer.
I mean, they're cheap. They're lapel microphones.
Yeah.
I would love a lapel
cheaper,
mic.
They're like more dynamic. Like it makes more sense.
Oh, because it's for no money.
Or can't you
Yeah, I
get
probably
somebody-
should be practicing. I'll have to do that on Wednesday when I lecture. I'm already in mode right now. So.
Why can't you get somebody to like change the slides for you? Like you make eye contact.
Because I have to always say next slide, next slide. That's just.
No, you could
Unless you have like a hand
Because
gesture.
I will miss on Saturdays, exactly, that you can practice. Because we've got to learn to stay for the one.
All right, there you have it, guys. Just a more elongated view of that area of interest. Once again, they have a very old picture in here. You know how I know it's an old picture? It's a circle. Anytime you see a circle x-ray, that's an old film x-ray. They used to do what's called cone collimation, which was a circular collimation. We don't do that anymore.
We definitely teach it.
But we still teach it. So what are we looking at? Well, it's in the name once again. We're looking at the body and the rami. We're elongating those in particular. Central part of the body will still not be seen well because it's superimposed. Thus why we're going to do a specific position for the body coming up. And if there's lateral displacement fractures, same as the other position, we're going to see them in a little bit better visualization on this view. Shaking?
What are those artifacts on the right side?
So like right here,
Yeah, the pepper stuff.
probably dust. I was to guess. So one thing with
Oh,
film
the
X-rays,
film, right.
that was a really aggravating thing about film is that dust particles and dirt always got inside the film. They would show up like little flecks, like little snowflakes like that.
Because it's in the anatomy as well. Like, were there a lot of misdiagnoses, or would they just fall for
I'm
repeat?
sure if you had an incompetent doctor, yes. But depends on who's reading the X-rays. And there are a lot of incompetent doctors out there, if you haven't figured that out.
You're in the county.
It's not just county. I supposedly work with some of the top best ones, and they didn't all suck, but a lot of them were pretty terrible there too. So, yeah, just all depends on their attention to detail, and how much they care about it too. Sad but true. All right, so evaluation criteria, of course, guys, entire mandible. When I say that, we're talking about that condyloid process down to the mentum of the mandible. And as you can see, they're very close to clipping the mentum of that mandible. Super close. Too close for comfort, if you ask me. No rotation or tilt, just like we've been talking about. Condylar processes, like I just said, because that is the entirety of the mandible. And make sure that the skull is smiling at you like this one is too. Because we don't want a frowny skull, we want a smiley skull. Because we can so make that happen, right?
Brownie skull?
No one's gonna call me out on that lie? Can you make the skull smile like that?
Mm-hmm.
No, you cannot. It's always smiling like that.
Mm-hmm.
We only smile with the skin, not the bones and teeth.
Some people use teeth.
No one caught that? No, no, getting tired.
I thought you were making like another violent joke.
Violent joke.
Yeah, like you like rearrange their face into smiling or something.
Trying to say
Frowning.
I have violent, dark jokes.
I don't know. Let's talk about.
I do, depending on my mood. Yes.
I mean, I thought about the Joker.
That's right.
What that's.
Just talking about the Krista Galley and nasal bones and all those shivs that you were thinking about.
Is there a movie where they do like a creepy smile?
I think there's a lot of them.
It's like a horror movie.
Smile. I've seen it. It's really
All right, now let's move on to the body, guys. This is going to be focused on the body portion of the mandible. Where's the body of the mandible, guys? Where's the body of the mandible? Right here, horizontal portion. We just went over the rami. Now we're on the body portion. This is going to really show off that body area of the mandible specifically. Still sitting upright. We are changing the position of the face. This is where people are going to make mistakes here, so be careful. So from rami to body, we now put the patient's nose and chin on the IR, or as I like to say, have them kiss the IR. Probably don't tell them to do that, but if you can imagine them putting their lips on the IR like they're kissing the IR, kissing the mirror, whatever, that's essentially what the patient's doing. So anterior surface of the mandibular symphysis is parallel to the IR. AML is nearly, if not all the way perpendicular. We're using the AML line on this one, which goes to the canthion. And MSP being perpendicular to the IR as well. The biggest change there, of course, is what we're making perpendicular. The fact that we're using nose and chin instead of nose and forehead, which we've been using for all the other ones. So be careful. It's a little subtle change that you can miss if you're not paying attention to those details. So if the nose and chin's on the IR, their lips are touching the IR, which is why it's really important you clean that surface off for them.
Especially after those chest X-rays, huh?
Oh yeah. If they shed hair all over the, yeah, I'm not gonna go there. That's a little too nasty.
Sweaty brain.
That's definitely one thing you will see at Harris Health. Nasty.
Some leftover chest hair on my arm.
Nasty.
Just nasty.
It's
Yeah,
not-
thank you.
let me tell you,
Just
it's not just Harris Health. Let me tell
It's
you,
a lot of nasty.
there's just nasty people out
Yeah.
there, unhygienic people.
Tell me all about it.
I mean, I went in, it's really not just Harris Health, guys. I've followed nasty techs that like left feces and pee on the tables and vomit like in the cracks and stuff. Or we'd have a bloody case on the C-arm. They didn't clean the C-arm off, so there's like all this dried, coagulated blood all over the C-arm. It is not just Harris Health. There's just some nasty people out there that don't clean. It's despicable.
I was just telling her I had a patient.
I'll tell you what. That one thing I didn't expect. to see-
One
Oh, okay.
Hang on, go ahead.
They were. She was a bigger patient, like easy 400, and they were trying to roll her so we could put the plate under her, and one of the nurses was like, "Oh, spicy in here." Like, she was a little rancid.
Wasn't very clean.
No.
Yeah.
I was standing at the door because I could smell it down the hallway.
And unclean human odor is some of the worst. It's-
There be a lot of homeless people in there, and I be feeling bad because they just smell it in the rain.
Ooh, okay.
Jay, what was your comment?
The,
Go to the next slide.
coagulated blood is something I didn't expect to see when I.
The what now?
Coagulated blood.
Oh, coagulated blood.
Like from OR, IR, just seeing clumps and it just, I didn't.
How it
know-
clumps up.
Yeah, just like before it falls off the, the blue, it's just already a gusher.
And let me give y'all a little pro tip on that, because you're gonna get in some really bloody OR or C-arm cases. My best advice to you is, as soon as that case is over, before you do anything else, clean it off. When that blood dries, you're gonna be sitting there for an hour scrubbing that blood off.
If you
It
put
does not come
hydrogen
off.
peroxide, it takes it off really quick.
It's still painful if it's like dried up. Try to get it while it's still fresh and non-coagulated.
I feel juicy.
Still juicy. Yes.
The previous slide, it says AML perpendicular.
AML perpendicular.
I can't feel the needle line.
And then.
That's what's gonna occur if you have the nose and chin on the IR. It says nearly, it's not gonna be exactly, but as near as possible being perpendicular. And then on that same subject, when we're talking about the central ray, guys, this is one of the only positions where we see this. It's gonna be perpendicular to the level of the lips. We want the area between the lips, by the way. So the central ray will exit in between your lips, this X-ray. Not the acanthion, in between the lips. And that's actually a line that we don't teach anymore. It's called the LML. We don't teach the LML anymore. There's a lip meatal line as well. Not sure why they removed that, but I guess they deemed it obsolete, so. Once again, tight collimation, guys. Think about the area you're visualizing. We don't need all the face and skull. We're just interested in the mandible. If you want to be really good, just look at the area of the TMJs. A little bit of light above the TMJs, a little bit of light below the chin. You're gold. It's exactly where you need to be. And TMJs kind of line up with your EAM, by the way. If you don't know how to find those, it's a little light above the EAM. We'll put it above the TMJs. All right, what are we looking at? Well, I hope we know because it says mandibular body, thus we're looking at the mandibular body. That horizontal portion, which you can see a lot clearer on this X-ray. Nice, beautiful collimation with a marker. We want the entirety of the mandible, which they do not have on this picture, by the way. Where are they cutting off?
The TMJs.
TMJs. Come on, Merrills, you're better than that.
Is that because of the centering?
It's because of that circle collimation.
Is Mr. Merrill's gonna be at the?
Mr. Merrill's dead, I think.
Oh.
He's been around a long time.
The guys with the book.
Dr. Johnston will be there, the one that wrote your physics book. He's usually there.
That guy.
Is that the split?
Huh?
This is a new
What now?
edition or something.
Yeah, I thought you
newest
had told us we
edition.
could meet Mr.
It's, well, I mean, it's based on the guy named Merrills. It's the newest edition, but the original Merrills guy, I don't think he's alive anymore. In fact, if you look at the front of your book, there's like all their portraits. There's a lot of people that wrote these books. I think it shows, I think it has their years.
Yeah,
Yeah.
Rollins, Long, and Curtis.
Yeah. That's a lot of the people that did the positions and stuff, like Schuler, Beclair, Fuchs, Waters. There's Mr. Waters right there, matter of fact, if you want to see what he looks like.
Hey, Michael.
Yes.
So, you said it was because of the circle aperture, but if they had centered like a little lower, would they have included it?
Honestly, I think they're centered too low, period, on this. Because what did I say the centering point
I'm
was?
sorry, higher.
The lips. And where are the
Right.
lips at? Up here. They're like more so on the mentum almost here.
We shouldn't be seeing the C-spine.
You should not be.
That's
This is a bad example X-ray. That's why I said shame on you, Merrills. You can do better than that. Especially you're gonna say entire mandible and not even show it on the picture, right? Makes perfect sense. All right, of course, no rotation or tilt. That has not changed, guys. It's gonna be for every position. Keep repeating that, just make sure you know that. Bless you. No rotation or tilt. There's a lot of dust in here that everyone's sneezing. Pollen season. It's got me too.
So we still wanna see the entire mandible even if we're doing the bottom?
Yes, yes you do.
Where am I in?
And reason being, kind of similar to how we talk about the sinuses, you're kind of killing two birds with one stone. Bless you. If there is a dislocation of the TMJs, you'll be able to see that as well. So a lot of times where we think the pain is not exactly where it is. It might be something else causing the pain. So you're being more thorough. All right, so here's the axial version. What's this gonna do? It's gonna further elongate the body area, give us an even better view. We're gonna have the patient perfectly sitting upright, same position at nose and chin once again. Anterior surface of the mandibular symphysis or the mentum parallel to the IR plane. AML is still almost perpendicular, and we're still utilizing that 30-degree cephalic angle. That's the big one again, 30-degree cephalic angle for these mandible x-rays. Not caudad, but cephalic. 30 degrees on this one. It's gonna be slightly different than for the body. Body was 20 to 25. I'm sorry, ramus was 20 to 25. Body is going to be 30. Yes, Jay? Raise your hand.
It says on vertical Bucky. I know that the picture is having them, prone. Is that because they're saying that the optimal way is to just have them upright?
That's their subtle way of saying it, yeah,
Okay.
without directly saying it. So kiss that table for me. No, don't tell your patient that.
I'm just like, how many pelvises have been on that table?
I know, right? You know, how many bottoms have been on that spot right there? Yeah. No.
Most people that take a nap there.
Thanks for the visual, sir.
We actually do fluoro in here sometimes too.
We do lots of barium enemas on this spot right here. Can you put your mouth, can you put your mouth there? We just had a really nasty barium enema before you came in. Just put your mouth on the table for me right there.
You'll be alright.
You'll be all right.
Wet one.
You said we hit it with a wet wipe?
No, I said give it a wet one.
All right, central ray is a little different, guys, than the last one. We're not between the lips. We're directly midway between the TMJs at a 30-degree cephalic angle. So basically, you're at the level of the TMJs for this one. A little fancier way of saying that. 30 degrees cephalic angle. So it does differ than the ramus axial we talked about. So you want that tight collimation, of course. TMJ is down to the mentum.
Good morning, excuse me, do you have any problems with your projector?
Yes.
Okay, he's here.
Oh, what time is it?
Time for a break.
9:37.
Come on in. I can take a break if you want to take a look at this. It's
Come on in here, Dick.
you want to take a breather?
We
So
appreciate you.
it's periodically just blinking in and out on the TVs and the projector, which is linked to this right here. So I'm not sure it's a wire or a short going on or something,
Yeah.
but yeah, there it goes right there. It's just like this.
We're back on the draw? We're back on the draw?
Not even a drive, man. Like,
Yeah, yeah. And I seen that, I was like,
I think we can call it a day there, guys, since we need to get this